I'd like to take our conversation to kind of things we can do. We have lots of folks, a lot of our participants here are working in public health, either direct client facing on the ground action or are public health decision makers. And I think that there's lots of strategies that certainly the four of us have heard from communities, or Angela, yourself are enacting at your health center and doing the work. And so I'd love to hear about what those strategies look like and how other communities can begin to implement them if they haven't already. And so I'll first turn it to you, Stephanie, in terms of what you've heard from Indigenous communities and especially the rural experience. I think a lot of the time the conversation centers on urban populations and those are the ones that get media attention, but there's a lot of work happening in rural and remote communities. If you can speak to that a bit.
Yeah, absolutely. Well, I just wanted to start off by pointing out that remote communities in particular are highly reliant on an outside workforce, right? And I think and Angela had alluded to that earlier as well, and that creates a high risk of disease introduction into the community, absence of health services, access to supports or resources entering into the communities. Rural communities are also at higher risk, they're more vulnerable and in comparison to our southern partners or southern communities in terms of the health infrastructure that is available in place and accessible as well, again, in comparison to southern communities. The housing situation is also important to keep in mind in communities which is very sparse and with multiple families living in the same household. And so there's also issues with sanitation and hygiene. So all of that is why I'm bringing that up as well. We see that certainly being factors for disease, for infection, but it's also important to keep those in mind in terms of why rural communities are also prioritized as well in light of those factors. There's been a number of initiatives that have been done to support access to the COVID-19 vaccines, to Moderna in particular, in northern and remote communities. The other thing too that I wanted to distinguish here before I continue is just how rural and remote is defined. I think they're often considered to be interchangeable or even used in the context of northern communities. And I think further clarification is needed in our conversations and how we are defining rural, remote, or northern communities. Because I think that's really important. Often these are communities that are left out of pandemic response and recovery. So with one example I wanted to highlight it's called Operation Remote Immunity, and I'm sure many on this call might have heard of this initiative. It's been talked a lot about in the news and identified as a successful example of Indigenous leaders, Indigenous-led physicians bringing vaccine access to 31 First Nation communities in Northern Ontario. So there was a number of things that I think I want to just highlight in this one example, and there's certainly others we can chat about, but I think this is one example that really touched on a number of key elements and considerations in their response to supporting vaccine uptake in those northern communities. Engagement, spending a lot of time engaging local community health leaders, the local health directors, working with chief and council in those communities. So establishing that relationship, working together collectively to determine or identify strategies or approaches to address fear and anxiety in the community around the vaccine. So that connects to messaging and communication. So what sort of messaging or communication was put out, but again, not doing that in isolation, but truly working with the communities to identify those approaches and the best strategies. Again, it's a constant, ongoing effort of ongoing dialogue, communication, relationship building that is really important. Operation Remote Immunity was a group that was led out of a number of key partners. One key leader in particular is Dr. Lisa Richardson from the University of Toronto. and a group of Indigenous physicians and non-Indigenous physician and students as well, going up to those communities. And there's 2 phases to that initiative. Phase 2 that is underway now is to bring access to youth in the community. And I think that's a priority in light of the recent news we heard about the outbreak up there, and now with the efforts to vaccinate children or youth 12 years and up. So some of the things that they've done was they used social media as a tool to support communication, putting out resources, pamphlets in the language of the communities. So in Cree, for instance, so those were really important as well. Setting up clinics in the community, again, and bringing in local community health workers and staff in the community as well. And these are trusted healthcare providers that the community that are, have a regular face and presence in the community, which is really important in addressing the earlier point we talked about around mistrust. So I'd say that really was grounded in these community-led, community-based initiatives to support vaccine uptake in the communities is community engagement, relationship, and culture. So relationships and culture, I'd say, really facilitate a strong vaccine response in the communities, and working again with the resources and strengths present in the communities to make this happen.
Thanks, Stephanie. Angela, I'd love to hear of the work you're doing at Parkdale Queen West, and what's being done to build some of those relationships, and what that looks like to partner with public health.
Yeah, so I would speak to I think in terms of broader than just our center, in that there is similar to the initiatives and the I call it the deep community engagement and partnership that has been happening with a number of community health centers across in terms of, Toronto, the GTA, the Greater Toronto area. So we'll speak to some of that, because I think one of the things that we saw in wave 2, when vaccine rollout initially happened at the start, is that vaccine rollout happened within long-term care, that we didn't see vaccine rollout happen simultaneously in communities where we had higher rates of COVID, higher rates of hospitalization, but also, which is where we have higher numbers of racialized low-income people, and where a number of those essential workers who work in the long-term care system are living. And so a number of community partners, among many others, did some mobilizing and troublemaking to push for vaccine being brought into those locations. And what we felt is, and that what we also saw when we began to see the availability of vaccine for some of these individuals, essential workers, is that it was through a registration system. And the registration system require that you have an OHIP in order to access booking your vaccine appointment. And we know, and I know that there are folks from the uninsured network, health network here in the city, in this event, and we know that immediately creates a barrier for having, in terms of an opportunity to get access to vaccine. 2 is that by having your registration access to vaccine be in this portal, this registration portal is, Angela, who is working on as an essential worker, at the grocery store or in the meat packing industry, she does not have a full hour, 2 hours to constantly refresh in order to get a vaccine appointment. So some of the mechanisms that were set up for vaccine at access were mechanisms that created structural barriers that led to structural inequality around vaccine access. So it was against this backdrop where community said we need to have what we call low barrier access to vaccine, and that vaccines need to be brought to the communities that are impacted, brought into communities, so where folks will come to trusted spaces that they know to access their vaccines. But then also there need to be the link and the engagement need to be done not by your distant public health from outside of the community, but by folks who we call ambassadors, health promotion workers, health educators who are part of the community, as a way to address issues of confidence, issues of hesitancy. So those were some of the strategies. Is one, creating low barrier access opportunities by bringing vaccines into the community, by having those vaccines be deployed at sites within community, and by having the education and the support be done by folks who are from and of the community. So trust is an important piece. As somebody says, vaccine deployment in certain populations will happen at the speed of trust. So having that happen was important. The other piece that I think we felt was also important is having the community be engaged and be involved in the actual vaccine deployment effort. Community health center partners are part of the vaccination team. They're part of the management of the site that are lifted up for the deployment of vaccine, and there is ownership in that process. And we see that as critical because that is the site of confidence. Because we also see that here is a moment as well where let us use the intervention in bringing vaccines to community to also set the frame for what we want to have in community moving forward after COVID. So what are the foundational relationships now that we need to build with community residents and healthcare system partners and healthcare delivery agents that will be needed post-COVID? The last piece that I would share as well as part of the trust in relationship, and I share this as, for me, when I think about an image around in terms of true community ownership and collaboration, was in one of the clinics that was mobilized by one of the community health centers, the Black Creek Community Health Center in the Jane Finch community, which is a community, high rates of COVID, lower rates of immunization, high rates of racialized people and essential workers, and high rates of hospitalization for folks who are impacted. Is the clinic that they ran had community members who were part of the, you need to warm the vaccine and bring it into a state of being for utilization. And it was older Black women who were sitting together in the, the vaccine draw area, who were hand-holding to warm the vaccine. And that for me was just such a powerful image and remains such a powerful image about the community owning, bringing safety to their community partners and to their community members. So I use that as an example where, as much as possible, where we can all integrate community members in that kind of tangible effort, because it speaks volume to your community to have, your aunties, your grandmothers, your mothers being part of bringing this life-saving resource to community.
Thanks, Angela. I love picturing that. That is a really beautiful and poignant image in my mind of what it truly means to involve community, right down to the warming of the vaccine. Sume, what have you heard in the interviews that you've conducted around strategies for engagement and building equity?
Thanks, Claire, and thanks, Andrew, for all this, for that imagery. I think a lot of what I'm hearing really resonates because, you know, Angela and colleagues have been really leading that work in the GTA. One thing which struck me as I spoke to folks across the country is that the responses really look quite different, just in terms of how the health system is partnering with communities. And the desire for community leadership is consistent across the country. And I think that has been where we've seen vaccine rollout, which is specific to Black communities and specific to other communities, other margins. Communities have really been leading that effort, which is a very different thing than community engagement, right? And I think in public health systems and health systems, we talk a lot about engagement, but then it's engagement while we keep the power for ourselves. While in the successful cases, the communities have really been leading the effort. So the power has really been in communities across, from the planning to the delivery, right down to warming of the vaccines, as Angela was sharing. So I think in places like Nova Scotia, we've also seen, you know, community Black specific clinics being run there. And it's similar ideas around community ambassadors. It's important for me to know that community ambassadors really would, it really has to be community specific. So for some folks I spoke with, they really talk about the importance, say, of religious leaders, which could be Christian leaders. It tends to be mostly like Christian or Muslim leaders. So really think about who are the leaders within your community. It could be, the leader could really be anybody, but knowing who those people who already have those relationships within communities are has been such a critical piece, and involving them throughout. And one piece I want to highlight is the communications aspect, because there has been the clinic, the delivery, which really I think has been specific to places like the GTA, some parts of Nova Scotia, but across the country, what has been consistent is community-specific educational efforts around the vaccine. And a lot of that really to counter some of the barriers and mistrust, which we all spoke to earlier. So what folks are doing in those educational spaces is, one, having Black physicians there, Black scientists being part of the conversation. There's been a lot of misinformation and disinformation, as I mentioned. So having people at the table who can speak to some of the sources of those, validate them as legitimate parts of the COVID experience, which we're all going through, and speak in support of the vaccine. So acknowledge the reality of anti-Black racism. I think for any of us trying to do work, if we go in not acknowledging the systemic inequities which exist and the ways in which our systems have frankly failed communities in such profound ways, then it's almost like we're coming from another planet. So really starting by acknowledging that reality regardless of what community we're working with. One thing which came up also was just representation, the communications, right? So who is speaking? So here the messenger matters as much as the message is what we're seeing with the COVID-19 vaccination in terms of the images which people have, the people who are actually in front. And an interesting example, which I know has been used not just in the Canadian context, but also in places like the US, is talking about the role Black communities have played in the development of the COVID-19 vaccine. So one of the researchers who really led the Moderna vaccine is an African-American woman, Dr. Kismeke Corbett. So people using her as an example to say, guess what? There was a Black scientist and she was leading this particular process. And it spills over just not from Moderna, but to all vaccines. And one of the conundrums is also that marginalized folks are less likely to be part of clinical trials. When we are, we're more likely to be abused by them, right? So you get the negative impact and less of the benefits. And I think in the COVID-19 vaccines, you've actually had quite a bit of, they've been intentional in expanding the diversity of folks who are taking part in that vaccine. So also bringing that forth to say, it's not yes, there's been experimentation. Right now, we're seeing a lot of transparency around the vaccine. It seems there's some degree of confidence that it's not experimental, that we have been involved in ethical ways. So really highlighting some of those examples. The last thing I'll mention, which is sort of a counter to this idea that we're sending vaccines into communities for the quote unquote general public, rich white folks, is to say, we recognize the abuses which have happened. And guess what? In spite of that, we need this to care for ourselves, right? Like for ourselves, it's also going to help us return to community because we've all been isolated. So really tapping into things which matter for community, that sense of community, but not from we need to protect other people, but really do this for ourselves, to protect ourselves in spite of all the harms which we've been subjected to by the systems.
Thanks, Sume. I just want to note for folks that there's been some great resources dropped into the chat box. I encourage you, if you have your own, to share with everyone here. We'll make sure in our follow-up email to include these resources and links to them so that you don't have to madly copy and paste as we go along here. And so thank you for everyone who's been sharing those. And certainly if you have questions to pose to any of us or panelists here, please put them in the chat box. We do have some time to get to them today. We have another half hour together, so certainly happy to answer questions. I wanted to share a little bit about what I've heard from folks who are working with individuals experiencing precarious housing or homelessness. There's been some really creative and, you know, I think really getting over the barriers of what public health does to reach folks who have a lot of trouble accessing vaccine because of some of those really systemic barriers that Angela pointed out. I mean, being appointment-based, being having to book online, even having to book on the phone. If people have minutes on their phone and they can't use up every single last minute waiting on hold to get a vaccine appointment or calling every pharmacy, that's a completely unfair expectation. And so being really low barrier is the term we hear a lot, but you know, I think that's really about being accessible and people-centered and patient-centered. I'm a nurse myself and have been working as an outreach nurse in the past, and I know that being just in community, being present on a continuous, ongoing basis is how trust is built. And so some of the strategies, such as mass vaccinations at shelters, so okay, we're going to have a blitz day at the shelter and we'll send in 20 public health nurses and they'll get it done, is actually not a great strategy because it's a one-off opportunity. And it's often sending in teams that don't have that trust established. And so using existing outreach teams or nurses or care providers or immunizers who are already tapped into that community, who already have a relationship, even if it's not that direct provider themselves, but provider with the same team, can make a world of difference in overcoming some of that mistrust that we spoke about. And the idea of ambassadors or using employees and paying people who are peer support workers, acknowledging them for their time, and teaming up nurses or immunizers with those peer support workers has seemed to be really effective in lots of different settings across Canada. And so for one example that I heard from, the nurses were kind of setting up tables on street corners and letting folks know that the vaccine was available. And then the peer support workers were actually kind of roaming the neighborhood, engaging with people, having a conversation about like, hey, did you know there's a vaccine clinic down the street today? It'll be here all day. It'll be here tomorrow. It'll be here next week. This isn't your only chance. So those multiple opportunities for engagement, I think, are really important as well. And that person to go out there and have those conversations, to be that trusted source of information. You know, it might not be the first moment that someone hears about the vaccine or the opportunity that they then want to engage. We're all of us are busy people with things going on and plans for our days. And I think especially for people living in poverty, thinking about how standing in line for a vaccine takes away an opportunity to be earning money during that time is an important consideration as well. And so not assuming that everyone can drop everything to go get a vaccine at a moment's notice. And then also there's conversations happening in different communities about actually incentivizing that. I like to think of it as acknowledging people for their time, especially people living in poverty who are giving up those earning opportunities in order to go get the vaccine. And so reframing it and rethinking of it of that way, I think helps overcome some of the unease that some people might have with the idea of incentivization. Of course, not wanting incentives to be coercive. We don't want that, and from an ethical standpoint, but I think it is important to acknowledge people's time. And especially those ambassadors and the folks in the community doing the hard work of that conversation and education piece. And something I encourage all logistical planners and people in public health to consider is how many times anyone who's engaging with our healthcare system has to engage with the system before they actually get what they need. And for many of these communities, and many people accessing all parts of our healthcare system, it is many, many times. You have to find your care card, you have to go online and book the appointment, you have to talk to a screener at the front door, you have to talk to the admin person at the front desk, and then you get to see the nurse. And that's 5 times for a simple immunization appointment. And many things are far more complex than that in our system. And each one of those presents a potential barrier to care. And so thinking about how we remove as many of those as possible and just get folks in front of the person they need to see at the end, I think really helps eliminate some of those systemic barriers.
So one of the piece, Claire, that you mentioned that I just want to pick up on, because I've been thinking about it deeply and trying to complicate it and our perspectives on it, is lining up. And relationships with lining up. It's layered. It's layered because I think that low-income people, poor people, have been accustomed to lining up for practically everything. Lining up for vaccine is not an abnormal event, yeah, because it's yet another resource that we need to access, that we need to line up for. And so for me, there's a complexity that we need to think about how the system pre-COVID, in COVID, and hopefully not post-COVID, build structures and processes whereby poor people, marginalized people are always in a condition of lining up to get access. Other people get to make appointments, yeah, and they get to have a schedule. And they get to know the predictability of when they will be seen. Yeah, so that's a pre-COVID. So the complexity of it for me, and so that is a systemic piece that I think we need to learn from COVID. We saw the long lineups, and we still continue to see the long lineups of folks in some of those communities accessing vaccine. So that's a systemic piece around the lining up. There are people's experience, I come from, racialized immigrant, come from a country where, yes, scarcity means you line up, you line up for flour, you line up for sugar, you line up for a lot of basic needs. So lining up a vaccine is like, oh, all right, what are we going to do in the lineup, right? So there's a different relationship. So when you have that history, there's a different relationship with the lining up, knowing particularly knowing if at the end of that line, you're going to get the resource you need. Folks who have no history of lining up and who find lining up disquieting because of their place of privilege want to have what they see as an efficient system that then have them push to create these processes that can in their own ways create barriers. So that's why it's some of that, the pushing for that online registration, because we don't want to see the lineups, right? And as well, when you see brown bodies and low-income bodies lining up, then suddenly the issue of security, how are those bodies going to behave? Maybe we need some police. Maybe we need security, because, things could go awry very quickly because, when those bodies congregate, then somehow we just, out of the wind, we just get violent, and we create chaos. So that issue of what then happens, and then what systems get mobilized. So one of the things that many of the sites, the community sites that were mobilized, decided is that no, we would not have security. Is that the community ambassadors would play the role of the line management and the relationship management, because we know what it means to then to have lineup mass numbers of brown bodies, largely immigrant bodies, and then when you add security on top of that, it creates, you know, a whole other set of dynamics and tension. And then so I think the issue of lining up is a complex one. And that it's not just we want a process that has no lineup, because different bodies' experience of lining up is very different. And therefore, what I think we want is we want to enable some systems and some structures that enable access with haste, but access nonetheless. So I just wanted to throw that piece in as we're thinking about how we mobilize our processes.
And thanks for that, Angela. I'm glad you're bringing in this question of security at clinics, because I know that in some places, there actually has been pushback when communities have said we do not want the police present as security at vaccine clinics. And I believe recently Durham went through that, and they ended up saying, okay, fine, as a compromise, because you had to compromise. They said, okay, we'll do it, but we want plainclothes police officers, and they must be Black. And that led to like a big explosion with the police and all that in that context. So even when, and for me, it just keeps raising this question of the incongruence with public health and policing, and how we in public health still continue to rely on policing, both which we do directly in public health, but also the policing as a formal institution to put forward public health measures. So as we think about COVID-19 vaccines, I think it's an important time to also think about how other systems are implicated, and how we're really sending out messages which are not aligned with what communities want and need. Because really, police, vaccines, I'm not quite sure the relationship there. So there's been that, which is I think a huge problem.
It would be interesting if they were bringing police to protect the vaccines, right?
Right.
Because there is such scarcity, but that's not what the police is being brought for.
It's a control and contain, right?
It's such an important part of the conversation. Thanks for bringing that forward, Angela.